I think it is in general underestimated how many of the people who are admitted with an acute ICH who are actually on an antithrombotic, being OAC or being an antiplatelet. If I look at the area where I'm practicing myself, about a quarter of the people admitted are on an OAC, and then about almost half on an antiplatelet. So basically, it's majority of the people we're talking about. Looking at that, there are more factors in it. This is about predicting who will get it. And basically, our ability to predict this is pretty low. The existing score was based on people on Warfarin, and the few data we have where we look at present cohorts. The Hasbled scale is not really strong in predicting who will get ICH. So that is certainly an area where there's an unmet need. If we look at the acute treatment, which I will be covering, the problem is that people with OAC-related ICH, they much more frequently have hematoma expansion. This means that the bleeding extends after the patient has been admitted to hospital. And the idea in the treatment is that we want to reduce this hematoma expansion. That is basically the idea of many of the trials in IAC overall, but in our population, the bleeding expansion, the hematoma expansion is much more frequent. So what we want to do in stopping the bleeding is mainly two treatment targets. One is to keep the blood pressure stable, and that is basically the same as with all patients with with ICH. The other thing is that we want to reverse the effects of the OAC. As to Warfarin, we have data from one randomized controlled trial showing that PCC is by far superior to fresh frozen plasma in reversing. We do not have data on how this really affects patient outcome because the trial was too small to give that kind of data, but the trend was that this improved outcome. Then when we get to the more novel, the so-called DOACs or NOACs OACs, we have the direct thrombin inhibitor Dabigatran. There is a specific antidote that has been well implemented, Idarucizumab, and we have some experience with that. When we get to the factor 10A inhibitors, there's also a marketed inhibitor, Andexanet alfa, but we have less data in people with OAC-ICH, and this has not been generally implemented, also because it is extremely costly, which has raised some doubts in the combination of not too much data and the costliness has arisen some moderate use of this worldwide. But a very nice trial is ongoing at the moment, a randomized controlled trial in ICH. So hopefully, based on the results from the MSci, which we hope will be terminated in about 18 months or something like that, we will be much wiser on this. And we're not using Andexanet alfa. People are using also PCC, but that is only based on theory and the efficacy in healthy subjects to reverse the effects of factor 10A inhibitors. So this is very weak evidence. So this is basically what we're doing. So this is an area with a lot of patients and a lot of low-level evidence.